into a palatless overdenture, and if he's happy with it, then we're going to copy that and we're going to make the final prosthesis. So here, this is his original. We have used all kind of things to block out with, but Teflon tape works better than anything. Because what you can do is you can just drape the tape over the locators. You don't have to punch holes or anything. You just drape it over the whole deal, and then come back and, like I said, we sandblast these housings now. And so we're going to go ahead and snap those into place. And you can buy this stuff. It's called Tape Tricks Fit Check, 18 millimeters, $37 for plumber's tape. Or you can go down to Ace Hardware and get it for like $1.50. It's the same thing. It's just Teflon tape. And so now we've taken his denture loaded with acrylic. You can see some of the Teflon extruded through those vent holes. And we're going to let this set up. And there's a bunch of stuff out there. Zest even has a product now that you can use to cure in attachments that's light cure. We just go back to using acrylic. You know, that's what I've always used. This bonds real well to the housings, and it bonds real well to the base. So we just kind of stick with that. Remove all that flash, and we're done. So now he's got a palatless, his original palatless overdenture. As I mentioned, we lost integration here. Here's the implant that we use to replace it. This has a much better prognosis than this ever would have. And this was a screw-up because we should have made a fixed bridge down here. So this actually came loose. We had to unscrew it, go back and make another crown. But other than that, the case is really done very well. But the thing that I want you to understand is taking his existing denture that he liked, converted it into a palatless implant locator retained overdenture, and then made a copy of that and took the final impression with that. So the lab could come back and make his final bridge with a metal reinforcement inside of it. And somebody was telling me that's the way McGinnis does all of his. He's got like an RPD, he's got a framework in all of them, because they will break them. Yeah, they really will break them. Okay. And next, we're going to get into some, like I said, we're going to do some removable. This is just another removable case. This is a lady whose son and I went to elementary school. He got killed in a motorcycle accident when we were seniors in high school. But basically, you know, unsalvageable dentition, falling apart. Back in the day, you know, I would use these mini implants so that we could get, you know, better initial stability with the overdentures, get rid of the palate, you know, use this also. And nowadays, if I put AnyRidge implants in the mandible, I'll put the locators on the same day and put the housings in and have that thing snapping in and out, because it's just such good initial stability. Or if I'm chicken, I'll put in some real long healing collars and relieve that lower to where it's really sitting on those telescopes and it's getting real good initial stability instead of doing this. Because these things, sometimes they fail, they get sore, and you got to take them out. Sometimes they hang around. In this case, she's still got most of them. But here you can see the metal reinforcement inside of her upper. You can almost see it inside of the lower. These things, you know, wind up staying. So not only were we curing in our locator attachments, we also had to include the O-rings. So the same thing up here. This case has been in a long time. This is what I want you to watch for is this. See that silver? When they start showing that, what you're going to find is your retention starts dropping off. And I don't know how to stop that. But here you can see the housings are sandblasted. So we go to cure these things in, the acrylic's going to stick much better to that sandblasted surface. So here we had our final bridges. We're checking to make sure with the fit check that she's not showing through anywhere. We relieve all these things adequately. You can see the metal frameworks that are incorporated into the overdentures. See right here where we mark with the pencil? That's where the fit check was showing through. Like over here. And there's where it's showing through. So we're going to relieve that again. And then finally, go ahead and cure these into place with quickset acrylic. And this is just the final deal. Like I said, I'll send them home with the black ones, and then we'll upgrade to blue. Usually 4 blues is plenty. And so that's what she's got here. Jimmy, there's your extended range. This thing must have been a little off parallel. And this is the final case. It's been in a good while, like maybe 6, 7 years, something like that, and doing real well. Here's a lady who came to see us that had a staple implant done. I think Carlton was in on this. I think they did it at the dental school. This thing has been in there forever. But she told me, she goes, the prosthesis has never stayed in. It's never been retentive. She says it's been a nightmare for 30 years or something like that. So the thing I was looking at is what she's got. I made her some new dentures. But what she's got is she's got this framework down here that's made to match to these two prong things. So we can't make her another framework. We can't get the parts. We called all over this. Couldn't get the parts. So what we did was we took the bar out of her mouth. We drilled a hole here and drilled a hole here and tapped it and screwed in a locator attachment there, screwed in a locator attachment here. And then here in the mouth, using this electric handpiece, we kind of milled what looks like a standard Preet bar so that we can incorporate this into the overdenture. So it snaps here, snaps there, and here's our third point of stability. And this has really worked out really nice. But the point is, she goes through this whole major big surgery thing, and the prosthesis never has really stayed in all that well all these years. This is a guy, I see quite a few patients with cleft palates, and part of it is Russell Romero, who's a friend of mine, who went to dental school, and then he became a plastic surgeon. He was just the guy. Everybody with a cleft palate kid would just go to him. He's real good at it. And he did a lot of, we have a clinic in Mexico where he was doing a whole lot of cleft palate surgery. And a couple times during surgery, he forgot where he was. Just forgot what he was doing. And at age 65, can't practice medicine anymore because he has early stage dementia going on, which is a real shock, man. So anyway, this is a patient of his. This guy's name is Andrew Dugas. He's got all this stuff going on. They put him in braces. Somebody put him in braces. And they really, I don't know what they didn't do anything. It still got a big anterior open bite. This was retained. Maybe that could have been moved. I don't know. But it was just kind of, I don't know. Anyway, we did this, put these rescue implants in on the top. I had him wear a snap-on smile. I've made like 4 of those in my life, and he was one of them because this guy's running around with no teeth. He's 17 years old. I said, well, let's try this snap-on thing. Man, he was elated. But after a while, I said, I think we can do better than that. So we got rid of some of this stuff, some problems on the bottom. Here's his post-ortho result. Look at the occlusion. It's just, not too hot. Look at this. So I don't know what they were doing in the orthodontic deal, but it didn't really turn out too hot. This is a snap-on smile that he wore for a couple, 3 or 4 years. And that worked out well for a while. It wasn't real aesthetic. It kind of looks like a denture. He was so happy to have something, after running around for so long with nothing at all. So we decided to upgrade. We put these rescue implants in. Here are the locator housings. We put the Teflon tape down over the locator attachments before snapping these into place. Here's the prosthesis that the lab made, metal reinforced. Made sure there's adequate relief in all these areas using Fit Check. Then we're going to go ahead and cure those attachments in the mouth. And we got 3 yellows. These are the bar attachments because we made a bar for them. And this is just the final result. The occlusion is, it's not what it could be, but it's kind of like the best we could do. I mean, this guy's like on cloud 9. He takes good care of it. It's just another instance of where implants can really help some people out that are really kind of a mess. So that's a removable. And then the last one I'm going to show, well, we have a lot more removable, is this lady here. This is like, I met this lady 2 weeks before my back surgery, and she's developmentally disabled. And apparently when she was being delivered, I don't know what happened, she didn't get enough oxygen, so now she's 55, living in a home. Her parents still treat her like better than y'all treat your own children, better than I treat mine for sure. But they bring her in, and they said, we want to see, our denture looks bad, and this and that, and this and that. So, look, she's got an infection, like, all over the place. Man, and Mama started crying and all this, and I said, what's going on? So, well, the dentist goes in there every 2 months and examines everybody and all that. But, I don't know, we kind of missed the boat here. So, I said, well, look, I got to go have back surgery. They said, well, she's got an infection. I said, she's been having this a long time. This didn't happen overnight. So I go have my surgery done, and after the deal. Now, she's developmentally disabled. She has an IQ of maybe 75. But it's like, you know what? If they want to do it, I'll do it. Take all these bad teeth out, put this in, and I'm leading up to something. Her oral hygiene is better than anybody's in my practice. And she's got an IQ of 75. When she comes in, I mean, those you can see yourself in the locator. I mean, everything is clean as a whistle. But instead of taking somebody that's developmentally disabled and offering them, you know, second-rate treatment, it's like, well, we don't need to make this available for everybody within reason, you know. So here's what she looks like when she comes in, you know. And this thing snaps into place. And the neat thing about this, I don't have a picture. They sent me a picture of her smiling before and after. And look, her personality just, whew, like 180 degrees. You know, now she's more talkative, she's more this, she's more that. Her parents and her sister, some of the most appreciative people I've ever met. And I almost thought, well, maybe I shouldn't recommend that. You know, she's not with the program. You know, maybe she's not going to take care of it and all this. And it's like, you know what? This is, if she was my sister, this is exactly what we'd do. You don't have to do this, but this is exactly what we ought to do. And I'm telling you, it had such a profound, it had a real profound effect on her personality. And so, you know, you start looking at things a little bit differently, you know, when you start doing a lot of this stuff. And it's like, this is the best thing that's ever happened in dentistry. You know, in 1985, Dexter Harrison and Hunter, were you there? Yeah. In Houston? Were you with us? It was 1985. We went to hear Niznik, and Dexter was doing his oral surgery residency. I said, what do you think? He goes, didn't look like a big deal to me. So we bought the Corvette system and started kind of using it. I started thinking, man, this is unbelievable that these things actually work. You start reading up Brandon Mark's research and all that. It's like, man, they're having all this success. Well, some of it was doctored a little bit, but the point is they were having some good success with smooth surface, commercially pure titanium implants. I mean, they were getting some success, and I started thinking, man, if I had to lose all of my teeth, I really would rather have that than dentures, you know. And here we are, you know, 28 years later, and it's much the craze in dentistry. I mean, it was unusual to see an article in any journal about dental implants, and now that's all you see, you know. And the scary thing is, it's almost like Lake Charles growing so fast. You know, they're going to spend $60 billion on a plant in Lake Charles, and Lake Charles is going to be a boom town. It's going to be like a gold rush over there, and you're not going to recognize the town, you know. And I'm afraid that this implant thing is growing so fast that we have to be careful about just offering it to everybody that walks in the door, or not keeping an eye on them, because when they get away from you, they come back 6 or 7 years later and say, you know, this thing doesn't feel right. And it's like, well, where'd the other two go? And this one doesn't have any bone around it. And where the hell you been? Well, I didn't know I was supposed to come back. You know, and so we really have to be diligent. I went to see a friend of mine that was a Catholic priest. We were talking, and I said, man, I'm worried to death about getting sued. And he goes, you need to quit worrying. You know, every time you get in your car, you worry about getting hit by a truck. You know, you have insurance, and they're going to pay for your car if it gets wrecked. You know, you have insurance. You need to quit worrying about it. And so I kind of quit worrying about it. I'm still careful, and I'm still documenting things and all that. But after 28 years of doing implants and 34 years of practice, 2 lawsuits. One had to do with the aesthetics of a case that another dentist did. Is a good friend of mine who did a great job. The lady was just insane, and they dropped the suit because there was nothing there. And the second one that comes along is over just a stupid error on my part, writing a prescription to somebody that was allergic. So it's like, you know, you worry all about implants and bone loss and paresthesia and all these things that can happen, and then something like that comes along. So I will tell you, on the board, we're reviewing a case where an oral surgeon had a death, and you know, it's boy, when you walk through, you know, what can happen, boy, it's scary. I mean, it really is scary. You know, we just get so routine about treating patients and all these things that, boy, we get so at ease, and I know I do, to where, you know, something can come out of left field, and you just don't know. You just don't know. So, anyway, let's move on. Joel, you have anything to add? Good, I'm flying. This is another example of some immediate loading. I started to show this a little while ago, but I didn't get around to it. This guy presents with this situation here. This tooth is falling apart. We've got a problem with this thing as well. And so what you see on the x-ray is this thing's in trouble. This has got a big old thing going on here. Okay? So we're thinking about, we take both of these teeth out, flap that big void here, debrided this out really, really, really well. Here's an implant in the number 8 position. This is number 9. That's a mini implant. And number 10, we put the implant in with the graft, but we're not going to load this. Okay? There's just too much happening up there. So we've got good initial fixation here, really good here, but I just wanted to cover all this up, let it sleep, and I'm going to use this to stabilize the provisional bridge. We're going to wind up taking this out later, okay? But we're just using it to stabilize the provisional because I don't want to put him in a flipper. I don't want him to wear an Essex appliance because I know he's going to hate it. So, you know, we've got a preliminary impression, put our peak abutment in, put this little thing on the O-ring, O-ball, and made this, went in the lab, you know, used flowable resin to create the emergence profile. This is a view of the underside of it. And here's the PRF membranes. There's my peak abutment right there. I took these with the iPhone, too. They're not that good. Joel, what do you have, Samsung?
Samsung.
Okay. Too late for me. Already showed those slides. And here's the provisional that we made in the lab. It's completely out of occlusion. That's before. Here's what it looks like on the CT. I mean, it's a mess. A real mess. And here it is after. Dr. Jimmy Babineau did this. Didn't y'all go to school with Brent Toops? Anybody in the room? I was just wondering. You did? Brent Toops from Rain, Louisiana? Real crazy guy. Do you remember him? Tall guy. We went across Lake DeCad last weekend, and man, my oil light went on. And the guy just worked on the boat. I go in the back, it's got no oil. There's no oil in there. And that's a 3-hour tow to go back in. So I'm in this canal, and I see these guys, they look bad, like they've been up all night. They're finally getting up to go fish. And I said, hey, y'all have any oil? And I see this tall guy reach down, and he pulls this thing up in the air. I said, hey, Toops. It's Brent. He's a dentist, retired from Rain. Real funny guy. So that was saved my behind. So here's this is his son-in-law, Jimmy, who's practicing in Lafayette now. And we wound up taking this out. We use that to support the provisional. We wound up just backing that right out, adding taking our fixture level impression, custom abutment here, custom abutment there. Actually, he made the customs. He wanted to do it himself. And so that's all that case. So in the anterior, we really do quite a bit of immediate stuff. Quite a bit. So here we're going to look at some removable stuff. I've had 3 patients since I've been in practice that have cried, where they were so overjoyed with the aesthetic result that we were able to obtain. Not one of them was a veneer patient or a crown and bridge. They were all denture patients, all 3 of them. Where they were just so impressed. Like Charlie English, who was a mentor, just a super guy. He was a prosthodontist in Augusta, and then he went on to work for Green Dental Lab up in Little Rock. And he used to say, man, there's nothing prettier than pink and white. He said, nothing looks better. And so we look at some of these different things that are out there. There was a slant lock, Dolda bar with the Hader clips, which we don't do anymore. Bar with locator attachments, which is fine, but finally we do a lot of more individual locators rather than using a bar, just because it's a lot easier. This was kind of a craze way back when, where you've got a bar where this distal feet are kind of angulated. They call it slant lock, where the denture, the superstructure slides into these foots. Then you have a little latch that latches under here. It really works well. It really works well, but it's a lot of lab stuff and commotion. And if you got to go back and make another denture, you know, here's your substructure inside of here. You have to make all that over again. So we didn't do a whole lot of these, but this is an old case. We did quite a few of these, and we'd have problems with breakage right here. We also have problems with people breaking the clips inside of the overdentures. But a lot of these cases, we'd wax up ourselves, send it off to the lab, have it cast. That's the wax pattern for the semi-precious metal Dolda clip. Send this off to the lab, get it cast up. You see how this fits real nicely over the clip, and then this is incorporated into the resin of the overdenture. And but this is a weak link. We see a lot of these areas break over time. So here we are blocked out with Play-Doh or modeling clay. We'll go ahead and make our occlusion rim, fix the case up. A lot of Straumann implants back in the day. Another bar case, Dolda clips. Does anybody go to school with Gilbert Coutois? He was a year older than us. Did you know Gilbert? He was a periodontist that passed away. He had MS. Yeah, you know what I'm talking about? This is his mother-in-law. Real nice lady from Boston. This is a case that we did a long time ago where we've got a subperiosteal implant, I think. No, these are root form implants, stereos in the maxilla. GC pattern resin, Doller bars, cast up in gold, and with these clips, it's okay. I mean, to me, the locator is just so much better, all the way around. So, did sinus lifts, some mandibular full subperiosteal implant. We don't do those anymore because they're a pain in the ass to do. And secondly, if you get any kind of strut exposure, it's a management nightmare. This case has worked out well, but it's too vulnerable to problems. Sinus lifts on both sides. These are Stereos Hexlock implants. There's the bar that I just showed a little while ago. 10 years later, take a look at this. Okay, look at these implants. 10 years later, look at what we got left. For some reason with those implants, you just started seeing the tissue and the bone resorb up vertically, and I don't even know why. I don't have a clue. And you see over here, we had some strut exposure, so we had to work with this. But this has held up very well. I mean, she's doing fine with this. But it's a shame because I had 8 in before. As I mentioned, we don't do much of this. This was done flapless. I think when you do them flapless, you can compromise this small, thin band of attached tissue. It's a very elderly patient. It really worked out well. It's economical. It's simple to place and restore, supposedly. Good long-term results. I don't agree with that anymore. Minimally invasive, I still do a full flap, so it's not minimal. And is it an excellent alternative for a medically compromised patient? Maybe so. Yeah, maybe so. Anybody do minis? Not much? They had the American Academy of Mini Implant Dentistry or something like that down here. And I ran into Howard Ferran at the hotel, and he was lecturing for him. And I said, will you do any of those? He goes, oh, no. I said, you just hear the lecture? He goes, yeah. That's what I do. Anyway, for a long time we used IMTech, Intralock are the ones that we use now. Every now and then they really have a good place in your armamentarium. But I find that it's like a lot of things, they're being abused. And some people are proposing to do 12 of them on the top and 9 of them on the bottom and all this stuff. And this is immediate post-op appearance. These are like little silicone sleeves that you place over the shaft before you put the O-rings in so the acrylic doesn't get locked on there. And then we'll take our existing denture, check with FitCheck to make sure that this thing is seating all the way, and then go ahead and use quick set acrylic in the receptacesites to pick up those O-ring housings, and then you're pretty good. So good case. This worked out well. This is the one I showed earlier where she wanted to keep these 4 teeth. I said, well, let me put a mini right here and a mini right there. And that's exactly what we did. The case did well for a while, and then she winds up breaking the, I showed you this earlier. She winds up breaking one of them, and then we put another one, and then she broke that one. So we put a real implant in. But this has held up well. This is a brush that we have patients use as an access brush from IMTech. It is good to use around these O-balls as well as locator attachments because it's got this collis curve design, and you have something that scrubs the top of the car also. So it really is pretty slick. I don't use this stuff. We use acrylic. We've used different things that are commercially available. They come in guns and all that. But we pretty much use acrylic for the most part. The thing about the Zest is I think that it's probably the best attachment out there right now. It uses less vertical height than everything else that's available. The patient can throw the denture in and bite down and not destroy them. We don't recommend they do that, but they really do tend to hold up very well over time. And that's kind of our go-to until somebody else come out with something better. They actually have more colors than this. For the most part, we use blue. It's 1.5 pounds of retention. If you try to put in 4 of these, they cannot get it out because that winds up being 20 pounds. But it's got a lot of advantages. It self-aligns. Like I said, it doesn't require as much vertical height as some of the, including O-rings, as some of the other attachments that are out there. So it seems to be the best thing out there. The story is, you ever heard the story of Max Zest, the guy that started the company? He and his dentist were good friends, and Max wanted all of his teeth taken out, and the dentist wouldn't do it. One night they both got drunk, and he talked the dentist into pulling all his teeth. So he was a lab guy, and he kind of wanted to see, I guess, what it was all about. So he gets all his teeth removed. He goes into dentures, and then he can't stand them. So he has vitreous carbon implants done. They all failed. Then he gets root form implants done, and he wasn't happy with the retention of the O-ring and so forth. So he developed the Zest, first the Zag, and then the Zest. He developed these things, and then he winds up passing away. And so his family has enjoyed his the fruits of his labor, because, man, I think the company's doing very, very well. And so when you look at an ERA, a Dowrow, O-ring, EDS, you know, this guy's going to take the least amount of height. And it's compatible with almost everything out there. You can handle divergence using the extended range. The extended range just doesn't have that little part in the middle that engages into the implant. You know, so if you're off parallel, you use something that looks like this, the green and the red. And like I said, there's a hard pickup material that MTech makes. We generally still use acrylic because I just find it works better. So there's all kind of bar systems. There's a castable deal, drill and tap, which is what we use. We're going to drill into the bar and then tap it, and then have a threaded locator that screws into the bar. If you laser weld it and the locator wears out, then you're kind of screwed. So you got to wind up cutting it off the bar and drilling and tapping it. Same thing with a cast too. So for the most part, we don't use those. So we're making a bar pattern. These are the castable patterns that are incorporated into the bar. This is 2.0 millimeter diameter. If you accidentally over engineer this and threading it, you can go to the next diameter, have a slightly larger screw for situations where something's been over tapped. And it comes with these tap drills, the threading tools. You know, we keep all this in inventory because we use this stuff from time to time. But as I said, we really don't do nearly as many bars as we used to do. It's a lot more about individual locator attachments. So I'm going to kind of breeze through this because I want to get to some cases. This is some old stuff. How many people are using locators? Yeah, I figured that. Yeah, they really have commandeered the market. These are old slides, so I want to get through these. And, okay, so here's the first case. We can look at locator attachments, all four positions, nice AP spread, most stable thing in the world, predictable, relatively economical. You know, we charge for an overdenture. I think for these attachments we charge $3.50 a piece, and for the overdenture probably something comparable to the cost of a partial, but a little bit more than that because there's going to be some service work. And one of the conversations that I had at a dental meeting in Detroit was I said, how many people in the room, if you had to lose all your bottom teeth, would have an overdenture? You know, and nobody raised their hands. Well, how many people would have fixed? And everybody raised their hands. And I said, you know, we prescribe this a lot to people, but we're not recommending fixed often enough. I don't know why. You know, we're maybe guessing their wallet and I think we need to offer, you know, what's out there. And if they can't afford it, they can't afford it. But maybe one day, you know, they'll say, hey, look, I want to get out of this and I want to go into fixed. So when we place these, we're trying to place them in the canine and molar positions when possible. So if they decide they want to go to fixed later on, you know, we haven't backed ourselves into a corner. And this is just our existing denture with clear attachments. That's 20 pounds of retention, real strong gal. And this thing, it just doesn't move one iota. This is the second case. This is a guy that had a bar overdenture, and the bar was so high up that it kept breaking through his existing denture. So we took the bar out, and you can see where that bar kept breaking through because there just wasn't enough room there. So we just took the bar out, put these individual locators in, took his denture, relined it, and to this day we haven't gone back and made another one of these. I mean, he's just done fine with it. But it was one of these things where, you know, you start stacking components where you've got an abutment, then you've got the bar, and then you've got the clip, and you have this, and then the acrylic and the denture tooth. And sometimes you can violate to the point that you've got a prosthesis that it keeps breaking. You see down here is where he kept breaking through that thing. Here's another case. You can tell this lady's had some dentistry done before. I mean, she's had some jaw surgery and some other things done, but but these teeth are falling apart. So the idea back then was, well, I'm going to put, this is '05, so it's 9 years ago.